Hello, my name is Quentin Broussard. I am an assistant professor of clinical sciences at California Health Sciences University, and today we'll be discussing hypovolemic shock. And the reason why we're talking about hypovolemic shock today is because hypovolemic shock involves resuscitation with fluids to maintain adequate tissue perfusion. As a result of this, it's important for pharmacists to be aware of the different fluid options that are available to treat hypovolemic shock and when to use those specific fluids. Our objectives today are to characterize hypovolemic shock, to differentiate between different hemodynamic monitoring methods to monitor hypovolemic shock. We'll also describe crystalloid and colloid solutions. We'll review water distribution in the body as it relates to crystalloid solutions and how crystalloid solutions actually disperse within the different body fluids or body fluid compartments. And we'll also discuss literature comparing crystalloid and colloid solutions in order to develop a therapeutic plan to treat patients who have hypovolemic shock. We'll start off with a case. We have QB, a 52-year-old female, presenting to the emergency room with altered status and dysuria. He's been stranded in the desert over the last 2 days and appears very pale and dehydrated. Upon admission, QB has a blood pressure of 78/42, so relatively low. He does not have any significant past medical history and is negative for infection. What type of shock does QB most likely have? Cardiogenic, hypovolemic, obstructive, or septic? The next question relating to QB's case is, which of the following should be placed to monitor QB's arterial blood pressure? An A-line, a central venous catheter, a blood pressure cuff or a sphygmomanometer, or a Swan-Ganz catheter? And the third question, what type of fluid should be used as resuscitation for QB? Should it be albumin, D5W or dextrose 5% water, hydroxyethyl starch, or normal saline? So after today's talk, you should be able to answer each of these questions with confidence. Just to give you a little background about what we're going to talk today in regards to hypovolemic shock. The incidence of hypovolemic shock is unknown. However, it is a relatively common disease state that is seen in emergency room and hospital admissions. Unintentional injuries that frequently involve bleeding account for a mortality of greater than 39 per 100,000 people in the United States annually. And bleeding is something, or an etiology of hypovolemic shock, which we'll talk about shortly. Natural heat-related illnesses account for greater than 600 deaths annually in the United States, and dehydration is another etiology of hypovolemic shock that we'll talk briefly about. So what is hypovolemic shock? What is the definition of hypovolemic shock? Essentially, hypovolemic shock is inadequate tissue perfusion resulting in circulatory failure. And this is usually as a result of extracellular volume depletion. So in your body, you have different fluids that are circulating around, such as blood or plasma. When these fluids are lost from the body, what happens is a state where you're not able to transfer nutrients as well as other things like red blood cells and oxygen throughout the body. And as a result, your body essentially starts to shut down. So hypovolemic shock is relating to extracellular volume depletion, particularly within the bloodstream. Now, you can also lose body fluid from the intravascular space into another space of the body, such as the peritoneum, through third spacing. And what third spacing is essentially a shift of bodily fluids from your intravascular space to your what's called the interstitial space. So these are spaces where blood shouldn't necessarily be flowing, and the interstitial space is something that doesn't necessarily govern things like blood pressure, which is something that involves your intravascular space specifically, or within the vasculature. So talking a little bit more about the etiology. So remember, hypovolemic shock involves some kind of blood, plasma loss, fluid loss, or some kind of shifting of fluid within the body. It can be either an internal fluid loss or an external fluid loss. So things that comprise internal fluid loss would be decreased oncotic pressure. So whenever you have a decreased oncotic pressure, remember, oncotic pressure is the pressure that is exerted to pull fluids into your vasculature so that blood can flow throughout the body. If you have decreased oncotic pressure, potentially as a result of things such as low albumin levels, that actually acts as a force to pull fluids away from the vascular space and into the interstitial space. And if you pull fluids from the vascular space to the interstitial space, that actually can not promote blood traveling throughout the body, and as a result, you may develop hypotension as a result of that. Some other internal fluid loss sources are cerebral, chest, and abdominal sources. So say if you have some kind of trauma to any of those areas, such as the head, the chest, or the abdomen, you might actually have a bleed that results in blood flowing from your bloodstream or your intravascular space to somewhere where it shouldn't necessarily be. And if you have blood loss like that, that can drop your blood pressure, and as a result, not get blood to the areas of the body where they need to be. Fluid accumulations in the bowel, the peritoneal space, and pleural cavities can also happen, and this can result as a result of third spacing or as a result of trauma. And also long bone fractures may be another source of internal fluid loss or internal blood loss, because remember, if you fracture something, usually it's a traumatic event. You have lots of bruising that occurs near that fracture. And that bruising, depending on where the fracture actually occurred, can be pretty severe, especially if the fracture is a big fracture involving a long bone. Now, in terms of hypovolemic shock, so remember, hypovolemic shock, we're talking about intravascular space. Things that can cause external fluid loss from your intravascular space are things such as going to the restroom too often or overdiuresis. So we have to watch out and be very careful in our heart failure patients who are on diuretics, for example. You might also have cases where people may lose fluids from the GI tract from nausea, vomiting. They may have an NG tube that gets suctioned out so that contents from their bowel actually get suctioned out through an NG tube that they may have. You may have patients with fistulas that are essentially disconnections that may leak out different types of fluids into places where they may not be. And then on the flip side of vomiting, you may actually have diarrhea. And if you have too much diarrhea or profuse diarrhea, that essentially is taking away some of that plasma from your body. And as a result, you may get very dehydrated and develop a hypovolemic shock as a result of that. You also may have some other external fluid losses from the lungs, as well as from the skin. So think about a patient who's been out in the desert, kind of like our case example, who has been out in the heat for a long period of time. Those people might have large amounts of sweat that, come in the form originally of plasma, but leak through the skin. And if you have so much sweat that accumulates, that can actually, deplete your total body water stores and result in hypotension. So this schematic here gives a little bit about the pathophys that I've been alluding to with hypovolemic shock. So it's a spiral, so you start here with normal circulatory function. Now, after a patient has normal circulatory function, what happens is that there is some kind of plasma or blood volume loss that occurs. And when that occurs, remember that plasma or blood is lost from the bloodstream. And as a result, because the bloodstream and blood is responsible for carrying oxygen to all of your vital organs as well as throughout your body, you may develop ischemia, which is lack of oxygen, with potential preservation of blood flow to the brain and heart. Now, whenever your patient has this initial volume loss, your body starts to prioritize certain organs. And your body feels as if your brain and your heart are your two most vital organs, and for good reason. Your brain is essentially governing all of the neurological function throughout your body, and your heart is pumping the blood throughout your body, and that's why it prioritizes those organs first. Now, what happens here, after you have an initial insult of ischemia, ideally you treat it with some kind of fluid, and we'll talk about the fluids a little later. And hopefully, by treating it with fluid, you may restore normal circulation with the fluid. However, this is not always the case. And you may actually have circulation that is not properly restored after you use fluids or vasoactive medications. Now, because your circulation is still not restored, then you get a prolonged global ischemia. So essentially, your whole body is lacking oxygen because it's not able to get oxygen properly from the blood that, potentially may be lost, or the plasma that may be lost. Now, as a result of that, you may continue giving fluids and may have circulation restored after that point, but you may have delayed recovery. Now, assuming that the fluids are not effective enough, you go into essentially what's called a shock state. So essentially some kind of state where you may or may not have hypotension, or an impaired delivery of blood to the rest of the body. And that shock, or hypotension, depending on which way you want to call it, may eventually result in injury to the whole body because your body has not been getting proper oxygenation. And at that point, you may still be able to restore circulation, but you might have a much more delayed recovery than you were at the beginning of the spiral. Or you may get prolonged injury still. And eventually it continues getting worse and worse and worse until you develop multi-organ failure. And that multi-organ failure can eventually even lead to mortality. So as you see here, it's kind of just a bad spiral that occurs as a result of some kind of plasma loss or blood loss, or some kind of interstitial shunting of blood from the intravascular space to the interstitial space, which we briefly talked about earlier. So how do these patients particularly present? So you may see patients that come in with arterial hypotension. So this is defined as a systolic blood pressure less than 90, or a mean arterial pressure of less than 65. And the way mean arterial pressure is defined is as 1/3 systolic blood pressure plus 2/3 of diastolic blood pressure. You may see patients who come in who are tachycardic or tachypnic, and this is essentially a stress response that results from patients not being able to oxygenate properly. You may have thirst because these patients may come in dehydrated, and that may be the source of their hypovolemic shock. Patients may become nauseated because remember in the last slide how I talked about the body prioritizing the heart and the brain. Whenever blood shunts away from all of the other places and just prioritizes the heart and the brain, the blood shunts away from the abdominal cavity. And as a result, you may get nausea from blood shunting away from the abdominal cavity. You may get an acute kidney injury or a pre-renal azotemia due to lack of blood flow to the kidneys, and this can result in a low urine output or even anuria or dysuria, which is defined as a urine output of less than 0.5 mils per kilo per hour. You also may see color changes in the patient's urine. As a result of shock, you may develop ultramental status or orthostatic changes. Since your body is not perfusing properly to all of your different organs, you may actually develop multi-organ failure. And there are many other different things in the presentation that you may see with hypovolemic shock as well. This just kind of gives you a little bit of a global picture of the things that can happen with hypovolemic shock. And obviously, if hypovolemic shock is not properly treated, you can also have mortality as well. How do you monitor hemodynamics? Monitoring hemodynamics is very, very complicated. We'll talk a little bit more about this on the second day whenever we talk about distributive shock, but I want to give you a little bit of basics about monitoring hemodynamics to get you kind of started. So typically we monitor blood pressure with a sphygmomanometer or a blood pressure cuff. However, and that's how we think about it on the outpatient side. The problem with this is whenever you have a patient who comes in with suspected shock, whenever you're taking the different pressures with the blood pressure cuff, the different pressures or the different pulses that you may be trying to detect may be inaudible during shock. Because remember, in shock, your body prioritizes certain organs, particularly your brain and your heart. So blood is not flowing through the extremities as well, and that's why you may not be able to get a blood pressure with a blood pressure cuff. So, as a result, blood pressure may be unreliable in these cases. In some cases, you may need invasive hemodynamic monitoring in shock, and those can be done with an arterial catheter or an A-line, a central venous catheter, a CVC, or a pulmonary artery catheter or a PA catheter. And we'll talk about what each of those are. An A-line or an arterial catheter you may be familiar with from last semester whenever we talked about acid-base disorders. And commonly, an arterial line is inserted radially, so in this wrist area of the patient, or it can be inserted femorally. What this line does is it can provide a continuous measure of mean arterial pressure as well as your blood pressure. So it provides a continuous measure of your mean arterial pressure as well as blood pressure. Another benefit from this which we learned from acid base last semester, is that you may use an arterial line to take ABGs or arterial blood samples. One thing about this line that's different than some of the other lines that you may be familiar with is that it's not generally used to administer intravenous medications. Remember, intravenous is into the venous area. Arterial catheters are inserted into arteries, so basically vasculature that carries blood away from the heart. Intravenous medications are inserted into venous circulation, which goes back to the heart. And there are some nuances in terms of administering intravenous medications because obviously intravenous medications are formulated to be given intravenously, not intra-arterially. They have different pHs, they have different pharmaceutical things that you have to look at. And that's why they're given intravenously, is because most of the time they're studied intravenously. So, the main point I want you to get from this is that medications are not generally administered into an A-line or an arterial catheter. The next type of catheter we'll talk about is a CVC or a central venous catheter. And this is actually inserted into the venous circulation, and the tip actually deposits into central circulation, as you can see here. So this central venous catheter, it looks like, is inserted close into the superior vena cava area, which is one of the largest, if not the largest, vein in the body. What this central venous catheter does is it provides a continuous measure of central venous pressure. What central venous pressure is just the pressure that the venous system is exerting back to the heart. So it's basically the pressure of these veins right here. So it's essentially a measure of the pressure coming back. And that's not necessarily the same as an arterial pressure, which would govern what your blood pressure is. Now, there are some problems with CVP in general. People do monitor CVP for volume status. However, it is not a reliable estimate of blood volume overall. It's just measuring the blood that is coming back in the venous circulation, not necessarily the arterial circulation, even though your venous circulation can be partly governed by your arterial circulation. It may be used to assess blood volume changes during early phases of fluid resuscitation. So if you have a patient who comes in with shock, for example, you may find some benefit out of using CVP in these patients. So say if they had like a low CVP to begin with, and then you start fluid resuscitating them and their CVP increases, that may indicate that your fluid resuscitation may potentially be successful, barring any other types of monitoring. Ideally, in most cases, particularly for sepsis, which is a type of shock we'll talk about with distributive shock, we want to target a CVP of between 8 and 12 millimeters of mercury for non-mechanically ventilated patients, and 12 to 15 for mechanically ventilated patients, because the mechanical ventilators that mechanically ventilated patients are on actually exert some pressure of their own. Some benefits of having a CVC or a central venous catheter is that you may actually procure venous blood samples from this line, such as your BMP, your hematology labs, LFTs, other things can be obtained from this. But you can also get something called a central venous oxygen saturation, or an SCVO2. And essentially what that is the percentage of oxygen that it actually returns back to your heart after oxygen has been extracted from the arterial circulation. So remember that our arterial circulation has oxygenated blood. And we say typically that venous circulation has deoxygenated blood. And that's true to an extent, because your SCVO2 target is greater than 70%. So typically what happens is, say if you have a normal patient with an oxygen saturation arterially of 100%, which is typical for a normal patient like you or me, once their blood goes through circulation and that oxygen starts getting extracted from the blood cells, only some of that oxygen gets extracted, about maybe 25 to 30%, an estimate. That's why we look at an SCVO2 to see how that oxygen is being extracted, because remember, our big thing in shock is we want to make sure our patients are properly oxygenated. And how do we do that? We make sure that they're properly fluid resuscitated and that they're receiving oxygen. CVC catheters may also be multi-lumen catheters, as you see here. They have essentially multiple little ports that you can insert or inject different things into, such as medications. Because remember, central venous catheters are inserted venously. The other type of catheter we'll talk about is pulmonary artery catheters, or PA catheters. And a PA catheter is also known as a Swan-Ganz catheter. The tip of this catheter actually deposits into the pulmonary artery. So remember back from basic anatomy and physiology, we have our venous circulation coming back to the heart. Then we have the right atrium here. We have a tricuspid valve here, and then we go into the right ventricle here. After you go into the right ventricle, then your pulmonary arteries connect to your right ventricle and take the blood from your heart to the lungs to be reoxygenated. So essentially the tip of that Swan-Ganz catheter is in the pulmonary artery. So what benefits does this have? So we can actually measure CVP this way as well, because remember, this is essentially correlating with our venous return or our venous circulation here. You also may be able to measure things such as pulmonary artery pressure, so the pressure within the pulmonary artery, a pulmonary artery occlusion pressure, a PAOP, and this is also known as a wedge pressure. And this is one of the measures that they use to actually determine volume status. You can measure cardiac output in liters per minute from this catheter, and some of these things are actually measured by a complicated process involving hemodilution and different dilutional methods. I won't expect you to know exactly how these things are measured, but I would expect you to know a little bit about each of these different pressures. You can also measure systemic vascular resistance with this catheter, which is essentially the clamping down of the vasculature, particularly arterially, after your blood leaves the aorta. And we'll talk a little bit more about these pressures on the second day of teaching shock. And you can also measure a mixed venous oxygenation saturation. So this oxygenation saturation is a little further down from the SCVO2, which we measured in the superior vena cava previously that we talked about with the CVC catheter. Now, with the pulmonary artery catheter, you may give medications through certain lumens of this PA catheter because it can be used to deliver medications, because at this point your blood circulation is very diluted and it's only up a little bit further from your central venous catheter where it would normally be placed. However, medication is typically not given through lumens of the PA catheter. The PA catheter is typically used to monitor all these different parameters that you see here. So, in regards to which one you can give medication down, a CVC is always your best bet in terms of giving a medication whenever you're looking at your different catheters. This is just a reference here of some of the different hemodynamic parameters and laboratory values. I wouldn't expect you to know all of these, but if a question did come up on a test, for example, I would give you the normal range of some of these different values, other than some of the ones I'm going to want you to know, which will indicate throughout these PowerPoints and in class. But this is just here for your reference. Okay, so how do we approach the treatment for shock? So the first thing that you want to do is you want to get your patient to the emergency room and get them hospitalized for severe circulatory insufficiency. You want to try to obtain venous access, IV, for fluid and medication administration, because these patients are going to potentially need lots of fluids, lots of blood products potentially, depending on what the different type of hypovolemic shock they have. And your general ABCs, so airway, breathing, circulation. So you want to make sure that they're able to breathe on their own. If not, they may need to be intubated or mechanically ventilated. You may need to potentially attach oxygen or nasal cannula to the patient, as well as some other masks that are available, such as CPAP mask. You also want to maintain their circulation, which is very important in the way that we can play a role as pharmacists in trying to properly fluid resuscitate these patients. And then we also want to obtain vital signs and a urine output assessment after they have been, after they have a urinary catheter inserted. Because remember, urine output is one of those indicators of potential organ failure, particularly with the kidneys. So if you're not having any urine output, you're not having any fluid potentially hitting those kidneys to make urine. You're having that kidney fail, essentially. Some of the non-pharmacological treatments will honestly depend on the type of hypovolemia that the patient has. So, if you have a patient who needs oxygen, you need to secure an airway, as we just talked about. If you have a patient who has massive amounts of blood loss as a result of trauma or surgery, you may need to physically decompress that blood loss, so apply pressure to it, or you may need to go in surgically, and even though this may be due to surgery, sometimes you need to correct the source of that blood loss, because if you don't stop the source of the blood loss, it's not going to stop bleeding. You also want to get stabilization of any fractures that are there. You will want to cool patients who have any type of heat exposure, so patients who have been exposed to areas of high temperatures will need to be cooled down. And you may need to administer wound care for thermal injuries. The treatment for hypovolemic shock involves correcting the underlying cause of the hypovolemia. Again, kind of what we just talked about. And providing volume resuscitation or fluid resuscitation, depending on what type of hypovolemic shock that the patient has. And the most common types of volume resuscitation will be associated with, as pharmacists, are crystalloid solutions and colloid solutions. And we'll talk about those shortly. But you also may have other blood products that play a role, such as packed red blood cells, FFP, platelets, and cryoprecipitate. And cryoprecipitate essentially contains fibrinogen, which acts in the clotting cascade to help form clots. So as a pharmacist, it will be important to know mostly about these crystalloid and colloid solutions. Y'all talked extensively last semester about different blood products that you may use in the hematology section of the course taught by Dr. F and Dr. Carpenter. So we're not going to really talk much about other blood products other than crystalloid and colloid solutions today. In terms of crystalloid solutions, so these are essentially your different salt solutions as well as your different dextrose solutions. The most common ones that you'll see in practice, particularly for hypovolemic shock, are 0.9% sodium chloride or normal saline or NS, or Lactated Ringers LR. 3% sodium chloride is typically used as a hypertonic solution in patients that have hyponatremias, which may be related to head trauma, potentially. You also have D5W as well that's available, and D5 half NS, or D5 0.45% sodium chloride that are available for use. So talking a little bit about the main ones, normal saline is also known as 0.9% sodium chloride, or NS, and it contains 154 milliequivalents of sodium and 154 milliequivalents of chloride. And you might ask, why is this important? Well, if you think about your patients may have different levels of sodium and chloride in their bodies. So typically we think of the normal range of sodium between 135 and 150 milliequivalents per liter, and chloride as anywhere between 95 and probably 105 or 110 milliequivalents per liter. This will be important to realize whenever we talk about the adverse effects shortly. In terms of cost, normal saline is relatively cheap cost-wise. It only costs a couple of dollars or a few dollars for each of these bags of normal saline that you see here on the right, compared to the other colloids, which we'll talk about shortly, which are more expensive. Some adverse effects you may see from normal saline include hypernatremia, because this number or concentration of sodium is higher than the normal bodily amount that we actually have in our bodies for sodium typically. You also may develop hyperchloremia as a result of the chloride level or the chloride concentration of the solution being relatively high compared to the 95 to 105 milliequivalents per liter we have in the body. And this can actually develop into a hyperchloremic metabolic acidosis from the chloride load. And remember, that is a type of non-anionic metabolic acidosis from our acid-base talk last semester. You might also have acute kidney injury develop from excessive chloride load. Now, this is not a precaution to not use normal saline compared to the hypernatremia and hyperchloremic metabolic acidosis, which may preclude you from using normal saline. Because remember, acute kidney injury in hypovolemic shock occurs from fluid load not going to the kidneys, essentially. So this acute kidney injury may occur from chloride load, but it's not the actual etiology of the acute kidney injury in shock. Remember, that etiology is because your patient is hypovolemic. The next solution we'll talk about is lactated ringers, and it's also known as LR. And it's important to know that lactated ringers includes 130 milliequivalents of sodium, 109 milliequivalents per liter of chloride, 4 milliequivalents per liter of potassium, 3 milliequivalents per liter of calcium, and 28 milliequivalents per liter of lactate. Compared to the colloid solutions, it's relatively cheap cost-wise, though it may be slightly a little more expensive or cost a few more dollars than normal saline. The adverse effects that you may have with lactated ringers include hyponatremia as a result of the sodium concentration of the lactated ringer solution being less than the typical 135 to 150 that we have in our body, as well as hyperkalemia, because this solution does contain potassium. You want to make sure that it's used cautiously, particularly in patients who have renal failure. And in patients who have renal failure, it may actually be better to use normal saline versus lactated ringers, because that potassium can accumulate and then you may develop hyperkalemia and result in arrhythmias from that. Here is just a generalized table with crystalloid indications. So for the two main crystalloids we talked about, which are normal saline or 0.9% sodium chloride and lactated ringer solution, these are used for patients who have intravascular depletion and who have symptoms. So these are patients who are actually in hypovolemic shock. Your other solutions are used for different indications. Your 3% sodium chloride can be used for intravascular repletion in patients with head trauma. The 5% dextrose, 0.45% sodium chloride can be used as a maintenance fluid in patients who only have mild symptoms of hypovolemia or dehydration. And your 5% dextrose solutions are primarily used in dehydration in patients with mild signs and symptoms of volume repletion. The main point to get from this slide is that these other solutions are not primarily used in hypovolemic shock, but they may be used in patients who have mild dehydration or mild euvolemic states. 0.9% sodium chloride and lactated ringers are the solutions to use in hypovolemic shock primarily. The reason why we don't use some of the other fluids like D5W in hypovolemic shock goes back to basic body water distribution. So in our body water compartments, and whenever we actually have different fluids flowing around in our body, typically what happens with our body water is 66% of our body water is stored intracellularly or within the cell, and 33% of it is stored outside of the cell or extracellularly. Within that 33% of extracellular fluid, about 3/4 of that is stored interstitially, so not within the intravascular space. And about 25% of that, or 8% overall, is stored intravascularly or within your plasma or blood. So how does that shake out whenever we're actually thinking about different solutions that we have available? So in terms of our different solutions that we have, now 0.9% sodium chloride and lactated ringers are essentially isotonic solutions. So they essentially are matching the tonicity of our typical blood and plasma. As a result of that, there's no fluid shifting that occurs whenever these fluids are administered, except for within the interstitial space and the intravascular space. None of that goes into the intracellular space because these fluids are isotonic. Now, going back to the slide previous, remember, if you don't have anything go into the intracellular space as a result of the tonicity of the solution, basically everything else will go extracellularly, which is what these isotonic solutions do. And remember, 3/4 of that goes interstitially, and 1/4 of that goes into the plasma. And as you see here, whenever you administer 1 liter of sodium chloride, 0.9%, or lactated ringers, 75% of that fluid goes into the interstitial space, and 25% of it goes into the intravascular space or the plasma. Now, dextrose is a little bit different, D5W. D5W is a hypotonic solution. And as a result of D5W being a hypotonic solution, what happens is that different intracellular and extracellular fluid is being interdispersed between the two. Because if you administer a hypotonic solution into the extracellular space, what's going to happen is then that fluid will want to redisperse into the intracellular space to make everything isotonic again. And that's essentially what D5W does. So D5W actually goes into the intracellular department as well as the extracellular department. Or compartment. I apologize. As a result, you see that 2/3 of your D5W is going intracellularly here. And then you see that of the remaining third, 3/4 of that is going interstitially, and of that going intravascularly into the plasma area, you see only 83 milliliters. So the reason why we actually use 0.9% sodium chloride and lactated ringers for fluid resuscitation is because more of that fluid is actually going into the intravascular space where we want it to go. We want those blood vessels to be full as possible. Now, it's not as effective to give D5W because, a lot less, actually 1/3 less, fluid is actually ending up in that intravascular space, and that's why D5W is not traditionally used in hypovolemic shock. And as you see here with D5W half NS, because it contains part of each different type of tonicity, the dextrose and the sodium chloride, you're kind of meeting almost at a halfway point here with these solutions. So I want you to be familiar with where NS, LR, and D5W fall within these different water compartments, essentially. The D5 half NS is something I don't want you necessarily to know it, and it's not bolded here. I do want you to also be familiar with the different components of the basic solutions, so NS, lactated ringers, and D5. So remember, tonicity-wise, sodium chloride and lactated ringers are isotonic, D5 is hypotonic. Remember, it's important to be familiar with all these different values that are here, because depending on which solution that you may have, you may develop electrolyte disorders as a result of your different solutions. It's important to note that lactated ringers has 4 milliequivalents per liter of K. And sodium chloride has much higher sodium and chloride, 154. all these numbers I would expect you to know for an exam purpose. So which crystalloid do you use? Do you use NS? Do you use D5? Do you use LR? Well, we kind of talked about not using D5 for circulatory insufficiency for the reasons we just stated. But D5 can be used for mild cases of dehydration caused by water deprivation. So you can use D5 or D5 half NS for those. For patients with circulatory insufficiency associated with hemodynamic instability, so patients who are essentially in hypovolemic shock with a MAP of less than 65 or a systolic blood pressure less than 90, you'll want to use those isotonic crystalloids, NS or LR. Because remember, those are the ones that give you the more bang for your buck in the intravascular space volume-wise. We talked about the crystalloid solutions, so now what we'll talk about now briefly is the colloid solutions. And the colloid solutions mainly comprise of blood products, the main one being albumin, coming in 5% or 25%. There are also other colloid solutions that are out there that are not really used much anymore, such as hydroxyethyl starches and dextran. These are not used because they have particularly bleeding disorders or ineffective bleeding related to them whenever they're used. Not necessarily in all patients, but they do have a higher affinity for that type of side effect. Also, particularly with dextran, there's more anaphylactic reactions associated with dextran, which is why it doesn't get used much anymore. So overall, in terms of the colloid solutions, other than our traditional blood products we talked about earlier, albumin is basically the go-to here. So what is albumin? We have albumin in our bodies, and it's essentially a plasma protein, which is provided synthetically as 5% concentration, which is also known as an iso-oncotic concentration, or a 25% hyper-oncotic concentration. Compared to the crystalloid solutions such as NS or LR, they are relatively more expensive cost-wise. Now with albumin, you also have the chance of anaphylaxis, though it's much less common compared to dextran solutions. And you also have risk of infection as a result of it being a blood product. To show you a little bit about how albumin works and how the 5% differs from the 25%. So remember we said that the 5% just now was iso-oncotic. So that means that there's no net movement between the interstitium and the intravascular space that you see here. So essentially, giving 100 mils of 5% albumin is almost like giving 100 mils of normal saline. However, if you give patients the 25% concentration of albumin, that is primarily used to shift fluid from the interstitial space to the intravascular space. And that actually is a result of increasing the oncotic or the osmotic pressure within the vasculature. And as a result, fluid will actually go from the interstitial space to the intravascular space as a result of giving 25% albumin. That effect is not seen with the 5% albumin solution. So kind of like what I just talked about, albumin 5%, 100 mils is about the same as 100 mils of normal saline. It's iso-oncotic. And it's used for acute hypovolemic states. The albumin 25% is used to pull fluid into the intravascular space. However, it shouldn't be used in all cases of acute circulatory insufficiency unless you give it with some kind of other fluid. And in this case, if you kind of work out the ratios, albumin 25%, 100 mils of that is equal to about 500 mils of normal saline, which is hyper-oncotic. So, we've gone over colloids and crystalloids. So now which one do we actually use in practice, and which ones can we use in practice? Well, really, you can use either one. But what's the data on that exactly? So there was actually a landmark trial done in 2004 called the SAFE trial. The title of it was a comparison of albumin and saline for fluid resuscitation in the intensive care unit. and it compared 4% albumin to normal saline, or 0.9% sodium chloride. It was a double-blind randomized trial that looked at mortality, survival time during the first 28 days of hospitalization, newly diagnosed organ failure, duration of mechanical ventilation, duration of renal replacement therapy, as well as duration of hospital and ICU length of stay. The baseline characteristics of the SAFE trial included almost 7,000 patients, and they were split almost evenly to receive either albumin 4% or normal saline. And the only baseline characteristics that had any statistical significance was the central venous pressure initially between the albumin and normal saline groups, which was 9 versus 8.6, which had a p-value of 0.03, which was statistically significant. But whenever you think about a central venous pressure of 9 versus 8.6, it's probably not clinically significant. All the other baseline characteristics were not statistically significant. In terms of the outcomes of the SAFE trial, of the outcomes I listed earlier, if you look at all of the p-values listed here on the right, all of them are statistically not significant whenever you compare the albumin and the saline group. So mortality, length of stay, ICU or hospital-wise, duration of mechanical ventilation, renal replacement therapy, or new organ failure or mortality, there were no differences between the groups. So that really begs the question, should we use crystalloids or should we use colloids? Well, there really wasn't any outcome data that was different between crystalloids and colloids in the SAFE trial. And considering that colloids are more expensive than crystalloids, what we tend to do in practice is say, if they're equal efficacy-wise, let's use the cheaper option. We're trying to contain cost. So in most cases, we'll actually use crystalloids more often than colloids. Though colloids do have specific places in treatment of hypovolemic shock, depending on your different indications such as disease states, the electrolyte composition of the fluid, as well as the electrolyte composition of your patient labs that you may have, etc. So, while it may not, necessarily be the best thing to use albumin compared to a crystalloid, cost-wise, it does have some indications in certain patients, like patients who need the 25% albumin to shift the fluid into a different compartment, for example. Here are the references for this talk today. We'll go over these questions very briefly. So we had QB, a 52-year-old male who went to the ED with ultramental status and dysuria. He was stranded in the desert over the last 2 days and appeared very pale and dehydrated. He became hypotensive but didn't have any significant past medical history and is negative for infection. What type of shock does he most likely have? The answer here is hypovolemic shock due to his dehydration and his history of being in the desert over the last couple of days. He doesn't have cardiogenic shock, which we'll learn a little bit more about whenever we talk about decompensated heart failure, since he doesn't have any past medical history for heart failure, and we don't have any cardiac output or cardiac index data on him. He doesn't have obstructive shock because he doesn't have any type of obstruction that we know of that is leading to his hypotensive state. And he is not septic as he is negative for infection. And we'll learn more about septic shock whenever we talk about distributive shock. Which of the following should be placed to monitor QB's arterial blood pressure? The answer here is an A line or an arterial line. Remember, arterial lines are inserted arterially most often into the radial artery or the femoral artery. Central venous catheters only measure things in the venous circulation. So things such as SCVO2 can be measured with a central venous catheter or a CVP. A sphygmometer is a blood pressure cuff. And while, yes, it may be able to monitor an arterial blood pressure, remember it is not the best option to use in patients who are in shock. As in shock, different organs are emphasized more primarily for blood flow, such as the brain and the heart. And a Swan-Ganz catheter would not be ideal for monitoring an arterial blood pressure, as it's actually monitoring a lot of the venous pressures that we talked about, as well as the pulmonary artery pressures. And then what type of fluid should be used as resuscitation for QB? And the answer here is normal saline. The second best answer here would be albumin, but remember from the results of the SAFE trial that whenever you compare normal saline and albumin versus each other, there's no difference clinically. So the next thing we look at is cost. So which one is actually going to cost less and be more cost effective? Well, that would be normal saline, as it costs dollars compared to albumin, which is more expensive and may cost, around $60 for 100 mils of the 5% or 25% solution. D5 percent in water is not the best fluid to use as a resuscitation fluid, since this is a hypotonic fluid, and we talked about the different water distribution between the different compartments and how it is about a third less than what you would get from normal saline or lactated ringers. And remember, hydroxyethyl starches are not really preferred anymore as a result of potential bleeding disorders, as well as a potential risk of anaphylaxis with this. Even though it might not happen often, it's still something where you would use albumin preferentially versus a hydroxyethyl starch as your colloid of choice. If you have any questions, please feel free to let me know. You can email me at the address that is shown here. Thank you, and have a good day.